bicarb of 32, it needs to be higher than 2.1.
Higher,
Yeah,
so like
make it 4.1.
0.41, okay.
All right, so what's your interpretation?
It's respiratory, compensated respiratory alkalosis because it's on the base side.
Okay, the PCO2 of 60 represents what? The lungs or the kidneys?
The lungs.
All right,
The
and,
ACO.
and you got an A sitting up there for acid. So how is it respiratory alkalosis? You got an A for acid.
I was thinking it went to this one.
If you're
Since
thinking
it's
that,
on the base.
then you need to write that.
Metabolic? Okay.
Is it?
I don't know.
You don't know?
It's metabolic.
You think? What makes you for sure? We call the PCO2
It's,
what?
it's the kidneys, so it's metabolic.
Okay.
Okay. Thanks. So it's metabolic.
What kind of metabolic alkalosis? Okay, I'll write that. Chronic metabolic alkalosis.
Okay.
Very good. Okay, number 4?
pH is really low, so it's an acid.
Mm-hmm.
PaCO2 is high, so it's an acid. Bicarb is low, it's an acid. And the base excess is an acid, so this is mixed acidosis.
Very good. Okay. Any questions? Everybody got this? Ebony, come up and do number 5 from yesterday. And this kind of patient, this kind of blood gas you see in what kind of patient? You can erase 1 and 2. What kind of patient? Will you see this blood gas here?
Isn't it like cardiac arrest?
Cardiopulmonary arrest. Why do I keep saying it? Because you're going to see it.
If they were all bases, is that still cardiopulmonary arrest?
No, absolutely not.
Okay. It's just the acid side.
Just the acid, yes. Good question, no. If they were both base, you would have the mixed alkalosis, but it'd be for 2 different reasons. You got a problem going on with the lungs, and then a problem going on with the kidneys that are not related.
pH is within normal range. PaCO2 is within normal range. Bicarb is within normal range. Base excess of 1.5 is in normal range. So we would say the patient is normal and also capnic.
Yes, very good. And I put that in there because I don't want you to take a normal blood gas and call it something it's not. If it's a normal blood gas, it is what it is. Okay? Kyle, number 6. That's all you can do is try. Okay. Ebony, I want to.
I gotta get a drill that in my head.
I think going over that yellow sheet will probably help doing that.
Absolutely.
One
Miller,
more.
we need one more.
write your interpretation down. Okay, the pH is acid, it's out of range. So is it acute or chronic? So you come unprepared. Okay, don't come to my class unprepared anymore, okay? All right, pH is acid. Somebody tell them, is it acute or chronic? It's acute, or the pH is out of range, so you can use acute or uncompensated. Either one, write them down, whichever one you want. You choose one. Okay. Now you have the PCO2 is acid, and the bicarb is normal. So what is the pH matching? Respiratory or metabolic? So write respiratory. And is respiratory acid or base?
And respiratory is acid.
Write it down.
Respiratory acidosis.
Okay? These blood gases, you cannot wait to study. I give you blood gases, you have got to study them. Make time, prioritize. Okay? If you need to see me, come see me. I don't want any excuses. No excuses. Yes.
Just to clarify, if we go over something like this, we're expected to have that done by the next time we see you?
Yes, every day I may go through blood gas.
Okay, so I thought it was done.
No. Every day. I remember I told you day one, I'm working blood gases in both classes.
Okay.
Blood gases is not something you can study for a week or two and get it. You've got to do it over and over and over and over and over again for it to sink. Okay, so if I give you problems to go home and do, I expect for you to do them.
Okay.
And if you don't, then I expect for you to say, I don't understand, and come see me. You have to. It's a method to my madness. And I know it's a lot, but you've got to do this every day. You've got to take the time to do this. I don't care if it's an exam or what. Take 15 minutes, 20 minutes, a half an hour to look at blood gases. You've got to. Okay? Okay, I was going to put I don't know, hopefully this will help you. I certainly don't want to confuse anyone, but I was going to put a quick chart up for you, a little graph that I used when I was learning blood gases. Some of you may benefit from this, some of you may not. I don't know. Okay, so here I got acid, here I got base. So when you have an acid pH, it's decreased. And in here, I'm going to put an increase in hydrogen ions. Would you agree?
Yes.
All right. When you have an acid PaCO2, it's increased, greater than normal. So you need to know what normal is. Any questions so far? And then when you have an acid bicarb, it's decreased, meaning less than normal. For some of you, this may help you. Some it may not. But this is how I learned blood gases. All right. Question? All right. Base, the exact opposite when it's base. And of course, this would be acute or uncompensated circumstances because the pH would be normal if it were compensated. The pH is elevated and the hydrogen ion is decreased. For PCO2, the PCO2 value is less than normal. And then for the bicarb, it's greater than normal. So for visual people, that may help. If that doesn't help, make up your own. Do something so you can get this in your head. And again, the arrows mean less than or greater than normal. So with this, we've gone beyond knowing what normal is. You have to know what normal is to look at this. And then you can make a call. Okay? So I said I was going to do that yesterday, and I forgot to do it. So there it is. All right, any questions with this? All right, now let's go back to pharmacology. What I want you to do is pull out the sheet that I gave you. I'm not sure what color it was. It might have been cream color. I think it was this color I gave you.
Yeah.
And it has RSC 211 and 231 self-assessment. Everybody have that?
Yeah.
All right, let's go through these. Did you do these?
Yes.
Okay, good. All right. Okay, let's start with Ebony. Do you have yours, Ebony? Okay. Well, we'll come back to you. Doyle, what is number 1? What letter did you have for number 1? P. All right, does everybody have P?
Yes.
All right, good. You have yours, Michael? Okay, we'll come back to Michael. Let's start over here with Danielle S. What's number 2? What did you have for number 2?
L.
L? Did everybody have L?
Yes.
All right. Number 3, Barbara?
M.
M? Does everybody concur?
Yes.
Did you all do this together? No, I'm
No.
just kidding. Good, good, good. I wanted to see because I said, oh, well, Kathy, I don't know if you're right or not. I just did it off the top of my head, and I said, let's see if you still got it, kid. Okay, number 4, Amanda?
D.
D, okay. Number 5, Ganya?
That's E.
E, okay. You find it, Michael?
No.
Okay. Ebony, number 6?
C.
C, agonist, good. Okay, Heather, number 7?
Q.
Q, parasympathomimetic, good. Erica, number 8?
G.
Good. Number 9, Autumn?
O.
Very good. Alidra, number 10?
I.
I'm looking at you and trying to say what number. Okay, next, Kyle?
11's K.
Good. Vagus nerve. 12? Kelly? J. Good. Oh, good. 13? Good. 14? Maria? H. Very good. 15?
A.
16?
F.
Good. And last but not least, bringing up the rear.
10.
Very good. Any questions? Now, I know that I didn't go over peripheral chemoreceptor and central chemoreceptor, but if you got answers to everything else, and you certainly probably looked it up in the book, right? So don't fret not, fret not. I'm going to go over in Module 2 in tomorrow's class, central chemoreceptors and peripheral chemoreceptors. I'm going to do that, okay? All right. So we're good with this sheet. You got the definitions. All right. These are terms you need to know when you talk about pharmacology. You have to know these terms, and so you won't be lost. And basically, a lot of them will be in reference to classification. And then what I don't have on here is increased 3,5 G and P, A and P. I don't have that on here. But you know the sympathetic nervous system is that 3,5 A and P, and the parasympathetic is the 3. Okay, catecholamine. Catecholamine, I didn't explain this. I didn't get to this. These are naturally occurring hormones in our body. And catecholamines would be the epinephrine and the norepinephrine. So that's really, is that PNS or SNS? SNS. So catecholamines would be SNS. Remember I talked about fight, fright, or flight. And those hormones are released. When they're released, those together collectively are called catecholamines. So it would be the SNS. and our short-acting beta-2 agonists, I haven't talked about long-term and short-acting. The very quick-acting, like epinephrine, would be categorized as a catecholamine. So whenever you see the word catecholamine, it means hormones, and if we administer a drug that acts like a hormone, it's quick-acting, because the sympathetic nervous system releases the hormone, your heart beats faster, or you breathe deeper, or bronchodilation, then it stops. Okay? So when you see catecholamine, think of epinephrine.
Does that raise the AMP?
Yes, it's increasing 3,5-AMP because it is the sympathetic nervous system, yes. Any other questions with that? Okay. I'm going to skip methylxanthine drug. I didn't do that. And respiratory stimulant. Prophylactic, what does that mean? You take birth control pills, ladies, men, you have sex and put on a rubber, what is that? Prevent. Prophylactic means to prevent. Asthmatics should take their medication even on a sunny day when they feel good, prophylactically, to prevent an asthma attack. All right? Some drugs are taken prophylactically. All right. I'll skip anaphylactic, come back. Hypersensitivity. What's another name for that? Bronchoconstriction in the asthmatic. Hypersensitivity. That means hypersensitivity in the airways. Who has hypersensitivity in the airways? Asthmatics. And what causes it? Allergies.
Yeah.
So hypersensitivity means allergies, nose runs, stuffy nose. Some people are allergic and they don't have asthma, but they break out in hives or rashes and they itch. That's hypersensitivity. Make sense? All right. Allergic reactions, another name for hypersensitivity. Right below it is allergic reactions. If an asthmatic has an allergic reaction, is it going to be an increase in 3,5-AMP or an increase in 3,5-GMP?
GMP.
Very good. Immunoglobulin E. What is that E for? Eosinophils. What kind of patient are these eosinophils? This is an immunoglobulin, meaning an antigen. An immunoglobulin, meaning not an antigen. Antigen is the allergic one. The antibody, What kind of patient are these immunoglobulins elevated in because they like to party? They don't want to do right.
An asthmatic.
Very good. So eosinophils are elevated in the acute asthmatic, right?
Yes.
Meaning they've been having recurrent episodes of asthma. Okay. Contraindication, side effect, I'll come back to. Those are just general terms. Congestion. What is another term for congestion? It could cause, but congestion simply means an accumulation of fluid. Accumulation of fluid. Or let's think of someone that has seasonal allergies. They don't have asthma, but they have seasonal allergies. And you know how your nose, maybe some of you have experienced this, your nose gets stuffy. Your nose is congested. Okay? If that is the case, and I'm not speaking of the asthmatic, what kind of drug would a person who has seasonal allergies and their nose is always stuffy need? An antihistamine. And antihistamines have what kind of effect in it? Nope. It's nasal stuffiness. It's not in the airway. It's up in the snods. A decongestant. And a decongestant is classified as what kind of drug? Alpha drug. Alpha drug. Alpha has nothing to do with the airway. Vasoconstriction. Remember? So if a person is congested, they need a decongestant. The drug classification is antihistamine. And what is the receptor? effect? Alpha. Got it? And that alpha drug is going to cause vasoconstriction in the nasal area and dry up the secretions, right? But what's the side effect of that? Because they're taking this medication orally and it's going to go through their whole body. It's going to elevate the blood pressure. Did any of you do what I asked you to do last week? Go to the drugstore, CVS, whatever, and pick up something and read the label? You need to do it. Don't just take my word for it. Yes, I know what I'm talking about, but don't take my word for it. Go somewhere whenever you have an opportunity and pick up some allergy drug across the counter and see what the warning label says. And it's going to say, don't take this medication if you have hypertension. And now you understand why. It's an alpha drug, and it's going to raise the blood pressure. However, antihistamines are classified as such. So a side effect is increase in blood pressure. Does that make sense? Does everybody understand what I'm saying? Yes.
So the medication that they make for people that have high blood pressure, I mean, is that considered an alpha drug?
No, absolutely not.
Because they'll say that it's especially formulated for people with high blood pressure for the cold. Like, I'm trying to think the name of it.
Well, that's not alpha. It is that if especially formulated for a cold, that's not alpha drug.
Oh.
No.
Well, because it's like it's supposed to act like a decongestant, but it's not supposed to raise their blood pressure. So.
Well, a cold and decongestant are two different things. So which one are you talking about?
I think I'm talking about decongestant, but I
Oh,
don't
okay.
think
Now
it
ask your
acts-
question.
It acts like the properties of a decongestant, but it's not going to raise their blood pressure.
That's Coracetine.
Okay.
That is a synthetic drug that they're making because they realize the alpha drugs will raise the blood pressure for those that have hypertension. And most people that have hypertension are conscientious of it, but hypertension is a silent killer. And a lot of people don't know that they have high blood pressure. So the FDA, in collaboration with the American Heart Association, have declared, and are working that by 2030, all food, whether processed or in a restaurant, salt content will be decreased by 50% for that very reason. Because hypertension is a silent killer, and the #1 cause of death in the United States is heart disease related to salt and processed foods. So Coracetine is in a class by itself.
Okay.
Yes. But people with high blood pressure take antihypertensive drugs. They wouldn't take an alpha drug. No. They would take a beta blocker. Okay. All right. Bronchodilation, is that sympathetic nervous system or parasympathetic?
Para.
It's sympathetic. And is it really the sympathetic nervous system, or is it a drug mimicking the sympathetic nervous system? It's a drug. Because asthmatics can't come out of bronchoconstriction on their own. They have to have a drug that mimics the catecholamines, or drugs that mimics the sympathetic nervous system, right? Is that an increase in 3,5-AMP or GMP?
AMP.
You guys are getting it. Very good. Okay, bronchoconstriction, the opposite, SNS or PNS?
PNS.
Increase in 3,5-AMP or 3,5-GMP?
GMP.
Good. Any questions? Okay, I'm not going to talk about steroids. We haven't gotten there yet, but we will. We will. All right. Synergistic, what does that mean?
Two
Two drugs. So at a cellular level, can we have this? Can we have that?
Yes.
Yes, we can. And these together are called what? Synergistic
Synergistic.
drugs? Does anybody know the name of a drug yet for this? Look on the sheet that I gave you. Don't guess. Ipratropium bromide,
Ipratropium bromide.
Albumin, or Respiratory. Right, Carbamide, and the new name is Respimat. These are synergistic. This is the what? Bronchodilator. This is the front door, right? And this is the what? Anticholinergic, right? And I call that back door. But together they open the door, right? And when I say open the door, they cause bronchodilation. Is this for the acute asthmatic necessarily? No. This is for someone that no longer responds to conventional bronchodilator therapy. We call it, I don't want to get into pathophysiology, but there is a term called staticus asthmaticus. Staticus asthmaticus means this is an individual who's had asthma for a period of time and they don't respond to conventional bronchodilators. So they need something else. So they may need this drug, and we haven't talked about, we will, COPD. They could use this drug. But if just a bronchodilator works, that's all we give them. But when we find that they've developed a tolerance to this, they need a little oomph. And so we will give them a combination of both. Okay? This is raising the 3,5-AMP, and this is lowering the GMP, and collectively it will enhance bronchodilation. Yes, Kelly?
I was, for some reason, the word chronic. Somebody who's a chronic first asthmatic would also.
Chronic.
Okay, just kind of.
Not the acute, the chronic. They don't respond to conventional bronchodilator therapy anymore. Doesn't work. They need something else. Are we going to stop giving them the bronchodilator? No. We have to give them something else. Boost it. Okay. And there's other drugs that are synergistic, but this is what we're focusing on now. Okay, anti-inflammatory. Why do you think I have that term there?
Because of inflammation.
Because of inflammation where?
In the lungs.
And what will inflammation in the airways do?
Constrict.
Cause a person to wheeze or constrict. Now, we don't necessarily give the bronchodilator for that. That term, anti-inflammatory, goes with the term function and action of steroids. Steroids are classified as anti-inflammatory. So some patients, in addition to needing a bronchodilator, need a steroid. And I'm not talking about the steroid to build muscles. I'm talking about corticosteroids, yes.
Is that right? Because my daughter had the croup last winter, and doctor said when they gave her this cough syrup, had steroids.
Yeah. Inflammation. Steroids reduce inflammation. Okay? So, mast cell degranulation is in what kind of patients specifically?
Asthmatics.
And I told you last week, everybody who wheezes is not an asthmatic, right?
Right.
So if they're wheezing or if they're experiencing bronchoconstriction, it's not caused by mast cell degranulation. One cause could be their airways are swollen, right? And so in addition to needing a beta-2 agonist, they may need a corticosteroid. So corticosteroids and beta-2 agonists can be synergistic, and we'll get into that, all right? Because that's a reason for why people wheeze. Okay, we'll go through that. Histamine release. What happens when histamine is released? In the asthmatic. Bronchoconstriction, mast cell degranulation, right? That's the chemical mediator, as well as serotonin and some other little boogers, right? They make the airway sensitive, hypersensitive. Histamine release, right? What about the seasonal allergy? I don't have that. I do, but I'm just saying. Person doesn't have allergies. Doesn't have asthma, but it's in August and September and their nose continually runs. It's histamine release. What kind of drug do they need? Antihistamine, right? They need an alpha drug, right? All right. So histamine is just one, not the only one, that's caused by mast cell degranulation. Phosphodiesterase, I'm going to skip because that goes with methylxanthine drugs. Prostaglandins. Prostaglandin is a hormone that is a standard hormone in men, but we do females have some. The only time this hormone is released, oh, I'm not going to tell that lie, that's not the only time. Let me just tell you this. Prostaglandins are also released during mast cell degranulation. Prostaglandins are one of those chemical mediators released during mast cell degranulation. So what will prostaglandins cause in an asthmatic?
Constriction.
Bronchoconstriction.
So they're part of the PNS? Are they part of PNS?
Mast cell degranulation is really not part of the PNS. It's called hypersensitivity. It's the chemical mediator released as a result of being exposed to something you're allergic to. So it's really not PNS. As a result of it being released, then it's overactivation of the PNS, and that's what causes the bronchoconstriction. Okay? Does that make sense to you?
Yes.
Yeah. I don't want you to associate this hormone with the PNS. No. Okay, mast cell degranulation, everybody know what that is? Okay, so let's go through it. With mast cell degranulation, or we can call it release of chemical mediators, we have serotonin release, not good in the asthmatic.
Histamine.
We have histamine release, not good. We have prostaglandins. And then we have leukotrienes. And I'm putting leukotrienes, and I'm not going to explain what they are now, because leukotrienes is a classification of medication you're going to learn. It's called anti-leukotrienes or controller medicine. So for now, just take my word for it. These are the chemicals, mediators released that irritate an asthmatic's airway and causes them to go into bronchoconstriction. Okay? And then the last one, I'm not really going to go through. Slow release substance, anaphylactic shock. Anaphylactic shock is very serious, but everybody who goes into anaphylactic shock is not an asthmatic. Anybody in here, I know, I hope not, but anybody in here perhaps have a child or you or a sibling or whatever, have to carry the EpiPen? Epi meaning the epinephrine pen?
Unlike us, we sometimes have to.
You have to. Yeah, because what happens when individuals are stung by bees or wasps or bitten by spiders or whatever, what happens is the release, the bite, or the chemicals from the bug gets into the system and the body goes into shock. And when your body goes into shock, it doesn't know what to do. So it will stop. And your lungs are part of that. And so you'll stop breathing. So people who have anaphylactic reactions have to have an EpiPen, and that EpiPen is epinephrine. They have to have the alpha effect to keep their blood pressure going. They have to have the beta-1 effect to keep their heart rate going, and they have to have the beta-2 effect to keep breathing. Alpha, beta-1, and beta-2 is all in epinephrine. Okay? So this is not necessarily what happens in the asthmatic. This is what happens to an individual that is allergic, let's say, to a bee or a wasp, and they go into anaphylactic shock. So it's very, very important, particularly for children, if they're able to comprehend, not to forget their EpiPens. Because they can forget it one time, and unfortunately they can die. But with the asthmatic, these are the boogers or the chemical mediators released as a result of the mast cells being broken down. When something is broken down, something is released. And this is released in the airway, causing bronchoconstriction. Right? Okay. Everybody understand that? Okay. We got antihistamine, which is a vasoconstrictor. What's another name for antihistamine or vasoconstrictor? How do we classify it? Alpha drug. So you'll hear me come in, particularly in the spring. I passed it. I came in suffering a little bit when the semester first started. I need alpha drugs. And I have some potent alpha drugs because I take Benadryl, but I can't take it and come to work because it makes me sleep 10 to 12 hours. Okay, decongestant would be the same thing. If a person is congested, they need a decongestant. That's an alpha drug, a vasoconstrictor. Make sense? You see how some of these terms are, they mean the same thing? And I want you to know them regardless of whom the author is. All right, this is the language we speak. All right. Stimulation of alpha receptors. If you get stimulation of alpha receptors, what you going to get? Vasoconstriction. Is that PNS or SNS?
SNS.
SNS.
Yeah.
Is that an increase in 3,5 AMP or increase in 3,5 GMP? AMP.
You should put vasoconstriction.
Yes, right above it, under with antihistamine is right there.
Okay.
See antihistamine? I got vasoconstrictor.
Yeah.
Same thing as stimulation of alpha receptors. Same thing as decongestant. They're synonymous terms.
Okay.
See it?
Yep.
Okay. Mucolytic is another classification of drugs that you're going to learn. It doesn't have anything to do with the PNS or the SNS, so don't worry about it right now. I just threw it in there. Okay, stimulation of alpha receptors. Stimulation of beta 1, beta 2 receptors. Beta 1 is what?
Heart.
Heart. Beta 2 is what?
Lungs.
Lungs. Okay, now let's go back to the top. Just hold your finger there and go back to the top. Look at the first bullet. It says the function of the sympathetic nervous system excites, stimulates, and utilizes energy. And so we call it the cardio accelerator center. Does that make sense?
Yes.
It makes it go fast. It releases epinephrine. Okay? It releases epinephrine. And I only gave you one function, but it actually does two. Number one, it can be chronotropic. The term is there, so I don't have to spell it for you. It's right there. Everybody say chronotropic.
Chronotropic.
Okay, chronotropic is dealing with beta 1. And what chronotropic does is increases the heart rate. That's chronotropic. And because it's the sympathetic nervous system, we say positive chronotropic. Positive means we know that's the SNS. I'm getting excited and just hollering because you guys are learning this good. All right. We know that's SNS. That's what that positive means, right? Mm-hmm. Okay. So let's talk about this person that had this full-blown cardiopulmonary arrest. They have no heartbeat. The doctor said, give them an epi. Okay, that's good, right? Because they have no heartbeat. The positive chronotropic effect in epinephrine is going to increase the heart rate. They had no heart rate. Unlock the door, please. I'm sorry. I thought I unlocked it. I think I locked it back. Okay. They have no heart rate. Give them some epi. It's got a beta 1 effect in it. What is the epi going to do? Well, they had no heart rate. So the epinephrine with the positive chronotropic, meaning mimicking the sympathetic nervous system, it's a sympathomimetic drug, it's an adrenergic drug. Everybody with me?
Yes.
It's going to increase the heart rate. And then there's another effect, which is on your sheet, positive inotropic. Some people say inotropic, inotropic, whatever. This is going to increase the myocontractility force. You know the myocardium?
Uh-huh. The heart.
Heart muscle. So it's going to increase that force. So that means every time that left ventricle pumps out blood, it's going to eject more. So beta 1 can do both. Epi does both. So The reason I'm doing this, there are some drugs. Listen to me. Somebody can have, well, let me go back to this myocardium. When the left ventricle pumps out blood, the purpose is the blood has been through external respiration. Everybody with me?
Yes.
Now it's got to be pumped out to the respective tissues for internal respiration, right? Well, when that left ventricle pumps out blood in a minute, that's called cardiac output. And cardiac output is what the arterial blood sends to the tissues for internal respiration. Okay? So when we say gas exchange between the arterial blood and the tissues, where did that arterial blood come from? Cardiac output, because that left ventricle pumped it out. Everybody with me?
Yes.
Everybody understand that?
Yes.
We have conditions where a patient can have a normal heart rate. Their heart rate is just fine. Their heart rate is 80. But they have a decrease in cardiac output. I'm going somewhere with this. So the doctors can administer a beta-1 drug, but it does not have this in it, because that will increase their heart rate. It will only have inotropic in it. It's still a sympathomimetic. It's still adrenergic, but it's beta-1 inotropic. Dopamine, digitalis, dobutamine, those are all beta-1 inotropic. The only purpose is not to increase the heart rate, but to increase the contractility force to enhance cardiac output. Why is cardiac output important? Because that's how the tissues receive arterial blood. So beta-1 can increase the heart rate if needed, or beta-1 can increase the myocontractility force, but a drug such as epinephrine does both. And so what kind of patient needs both? A full-blown cardiac arrest patient. They have no heart rate, they have no contractility force, they're not breathing, and they have no blood pressure. So they need alpha to raise the blood pressure. They need beta-1 chronotropic to increase their heart rate. They need beta-1 inotropic to increase the myocontractility force. And until we get there, that's when we do BLS. Make sense? Mm-hmm. And then they're not breathing, so they need beta-2 to get them going. Any questions?
Did you say beta? What was beta-1 for? The increased heart rate?
Increased heart rate is on your sheet.
Okay.
To increase the heart rate and to increase the myocontractility force. Either or. But I'm showing you, I'm telling you this because there are some beta drugs that will only increase the heart rate, and there are some beta drugs that will only increase myocontractility force. It's in the first bullet at the top. Yes.
But beta-1 does both, it increases the...
Beta-1 does both, but man has gotten smart and said, well, we don't need it for both. Drugs are made for this, and drugs are made for this. Who has dopamine? Did I give dopamine to anybody for a research drug? Did I give digitalis to anybody for a research drug? Nope, I sure didn't. I left it blank. Bill, you have digoxin. That's what I was looking for. You have a beta-1 drug, but it is not chronotropic. So when you classify this drug, you're going to make sure to tell me that it's beta-1, it's sympathomimetic, but it is positive inotropic only. Only. I knew somebody had to have one. All right? So there's drugs that can do both, but then there's drugs, and then there's other drugs that only increase the heart rate. Does that make sense? Why do we need to know this? Because we know cardiopulmonary. Do we administer these drugs? No. But if you come in and you're dealing with a patient, you need to know because The cardiac output determines internal respiration. And why are we concerned with internal respiration? 98% of oxygen is carried through hemoglobin. And how does it get there? Through cardiac output. Make sense? We need to know. Only 2% is PO2. Minimum. So we need to know what cardiac output. We want to know what is the blood pressure. How well is that arterial blood getting to the tissue? So even though we don't administer the drug, we want to know what is cardiac output doing. How much of that arterial blood is getting to the tissues? Because 98% of oxygen is being carried that way. Does that make sense? It's important. We have to look at things three-dimensional. And I know it's a lot, but once you get into clinical and you start seeing this stuff, you'll understand that, but you might not know how to spell your name backwards. I guarantee. I guarantee. Okay, so the function of the sympathetic nervous system, it excites, stimulates, and utilizes energy. We call it cardioaccelerator. So you'll see positive names. Beta 1 is positive chronotropic. That increases the heart rate. And positive inotropic, that is for what? Increasing myocontractility force. See it there? Mm-hmm. Any questions? These terms are in your pharmacology book. These terms are in your cardiopulmonary A&P book, chapter 5. They're there. Do some research. All right? They're there. Inotropic and inotropic. Inotropic and chronotropic. So let's say, let's do this. If a person has a heart rate of 127, do they need a chronotropic drug?
No.
Absolutely not. They need a what kind of drug?
Negative.
Which is what? A beta blocker. You kidding it? There you go. There you go.
That's gonna
To block the heart rate, slow it down. Right. Very good. Yes.
Yeah, it's going to slow it down by dilating our arteries.
No. No. When you dilate the artery, that's the blood vessel. I'm only referring to the heart. When you look at the circulatory system, it's three things in the circulatory system. The blood itself is specialized tissue, the heart itself, and then the blood vessels. So if we're dealing with blood vessels, is it constricting or dilating? Constriction is alpha. Vasodilation is another ballpark. I'm talking about the heart. I answered your question? Yeah. Okay. All right. All right. Next is mode of action. What do you think mode of action means? In reference to a drug.
How it works in the body?
Not how it's administered. That's called route of administration. What did you say?
How it works in the body?
How it works in the body. What's the mode of action? So, if I say we need to give a patient a bronchodilator, what's the mode of action? Bronchodilation. Just that simple. What's it going to do? If we give a patient an alpha drug because they have allergies, what is it doing? What's the mode of action? Vasoconstriction. Got it?
Yes.
Any questions? Please ask me some questions. Make some flashcards. Or do whatever. Maybe auditory people, I don't know if flashcards will work for you. But you got to do something. Because these terms are really synonymous. Okay, trade name, generic name, we're working on those. Now look at this, positive chronotropic effect. There's that term again. Is that PNS or SNS?
SNS.
Okay, is it inotropic or chronotropic? Everybody tell me chronotropic. There's the word right there.
Yeah.
All right, that wasn't trick. Is it going to increase the heart rate or increase the contractility force?
Heart rate.
Very good. There it is. That's SNS. Is it beta 1 or beta 2?
Beta 1.
1.
Excellent. Everybody getting it? All right. See, it's not that difficult. It's just how you approach it. It's not that difficult. All right. Positive inotropic effect. Is that SNS or PNS?
SNS.
SNS.
Good. Is it an increase in 3,5-AMP or increase in 3,5-GMP?
AMP.
Good. Does it increase the heart rate or increase the myocontractility force?
Contractility.
Very good. Getting it?
Yes.
All right. Now, next. Negative chronotropic effect. Negative. No, it wouldn't necessarily be a beta blocker. If it says negative, let's go back up to the second bullet. Go to the top. See the second bullet? It says the function of the parasympathetic nervous system conserves and reserves energy. It's called cardio inhibitor. Okay? So now this says negative chronotropic effect. Is it PNS or SNS? PNS. Very good. And it's chronotropic, so will it decrease heart rate or decrease cardiac output?
Heart rate.
Excellent. Decrease heart rate. Got it. You getting
It's
it?
starting to click.
Yeah, get it click. Any questions?
You said it's not, it can be a beta blocker though?
Nope.
Oh.
Beta is what?
Heart.
Sympathetic nervous system.
Sympathetic.
This is parasympathetic nervous
Parasympathetic.
system. Now, yes, you can have this kind of drug and a beta blocker. They would be synergistic. Yes, you're on the right track. But whenever you see beta, whether it is accelerating or slowing down, its beta is still sympathetic. So if it's a beta blocker, look at this. If it's a beta blocker, she asked a very good question. If it's a beta blocker, it causes a decrease in 3,5-AMP, right? That's a beta blocker, yes?
Yes.
And how do I know? Because it's blocking the sympathetic nervous system, yes?
Yes.
Yeah.
All right. But this drug here is negative chronotropic effect. Negative chronotropic effect would be the PNS. Okay, would be the PNS. So what would this be? This would be an increase in 3,5-GMP.
GMP.
And so these are synergistic as well. That's just for the heart though. Because we can't give this kind of drug to what kind of patient? Asthmatic. Because what is that going to do? That's going to cause bronchoconstriction. So we can't give this to an asthmatic. See, if it was an asthmatic, we'd have to do something else. Because even though we're talking about the heart, this would kill an asthmatic. You see? All right. This is why some drugs are contraindicated. We know why we should give it, but we can't give it to this patient. Make sense? Yes. All right. If you're allergic to iodine, anything with iodine in it is contraindicated. All right. Negative inotropic effect. First of all, is it PNS or SNS?
PNS.
PNS.
PNS. Very good. Is it going to lower the heart rate or lower the cardiac output?
Cardiac output.
Output.
Very good. Very good. Adenocyclase. Well, I got there right there for you. SNS. Here it is. AMP. Adeno. That's the enzyme to speed up this reaction. And the one below it is guanocyclase. Here's the G. AMP is for the sympathetic nervous system. GMP is for the what? Parasympathetic nervous system. There they are. Got it? And when I say got it, I'm not expecting you to know it, but at least when you see the terms, you can associate them together. Okay? Okay. Cyclid 3,5-AMP to 5-AMP and cyclid 3,5-GMP to cyclid. Well, okay, this is what happens. How am I going to explain this? Okay, when you have a reaction in the body, or let's say we give a drug. Let's say it's short-acting. Short-acting means that we're going to give it, the patient should respond. No, I'm not going to say the patient will respond. Short-acting means that we give the drug, and the drug goes in and does immediately what it's supposed to do. Okay, that's what that means. But then everything that we give, let's say even if it's not a short-acting drug, it's an antibiotic. The doctor has given you a prescription for 10 days, right? Mm-hmm. But the doctor says you've got to take it 4 times a day. 4 times a day. Meaning every dose that you take, it has a peak effect, but then that drug is going to be broken down and excreted. Everybody with me? So you got to take it 4 times a day for it to be effective for 10 days. And then taking it 4 times a day for 10 days, the infection in your system should be eradicated, yeah? Okay, same thing with our respiratory drugs, cardiac drugs, or whatever. When the drug is administered, it has a peak effect. And based on the duration of the drug, it's only going to stay in your system, and then it's going to be broken down. All right? So if you look at the first term of the last two, it says cyclic 3,5-AMP. Cyclic 3,5-AMP, when we have AMP up, what do we get? Bronchodilation. But maybe we have to go back to the patient every 3 hours. Why do we have to keep going back administering the same drug every 3 hours? Because the drug has reached a peak effect and it breaks down, right? So if you look at this last one again, cyclic 3,5-AMP. 3,5-AMP, that's the peak effect of bronchodilation. But then there's an enzyme that comes in and it breaks that down. What are enzymes in your body?
Catalyst.
Catalysts to do what?
To stimulate a chemical reaction.
To stimulate a chemical reaction. So we've administered our beta agonist, our sympathomimetic, and we've gotten this. This is wonderful. And we know this is bronchodilation, yes? Mm-hmm. But the peak effect, that drug is only going to last so long. It's only going to last so long. And then there's this enzyme, and I'm going to give you the name. This enzyme is called phosphodiesterase. And how do I know it's an enzyme? Anytime you see an ACE on something, that's an enzyme. Did you all learn that in chemistry?
Yeah. Yes.
All right. Anytime you see an ACE, that's an enzyme. After the drug, whatever it is, reaches its peak effect, maybe the drug is only going to last in the system, I'll just pick 6 hours. And so maybe about 5 hours and 15 minutes, maybe the patient doesn't wheeze. Dilation has done what it's supposed to do. But now my body can't remain in that state of my sympathetic nervous system being activated. Everybody with me? Because normally, physiologically, my sympathetic nervous system lies dormant. And it's got to go back to lying dormant. One of the side effects patients complain of is tremors. They say, I don't like to take this drug because it makes me shake. That's a side effect of their overstimulation. So anyway, bronchodilation has occurred, the drug is effective, but physiologically, and we can't stop this, phosphodiesterase comes in and breaks it down, and it breaks it down to 5-AMP. No more bronchodilation. So that means if the patient's in the hospital, it'll be time, whether it be Q3 hour, be Q6 hours, whatever it be, we may have to make that determination. We got to go back and give them another treatment for this to happen. Because phosphodiesterase comes in, and remember, when we talked, we didn't go into the detail, we talked about ADME, absorption, distribution, thank you.
Metabolize.
Metabolism and excretion.
Excretion.
This phosphodiesterase comes in and it breaks this down, and this drug is metabolized and we excrete it. Anything goes in your system, it's got to be processed through your body. So this is why we have to go back and administer the bronchodilator again, and then educating patients on the importance of taking their drugs even when they feel better. Because if they get in this state, let's say, okay, this is fine, they're not wheezing, allergic to dust, and they're not taking their medication. If they're allergic to dust, they're wide open for 3,5 GMP. And if they're wide open for 3,5 GMP, then we know they're going to deal with bronchoconstriction. Does that make sense? This is physiologically what happens every time, whether it be the drugs we administer, but I'm speaking solely to our drugs. This effect is only going to last for so long. And this effect has to be broken down, and phosphodiesterase breaks it down. And then now, at a cellular level, the patient is only at 5 AMP. That's not bronchodilation. So they need to take their drug again to keep from wheezing. Because let's say they came in the hospital and they're really bad. Just because we gave them a treatment, the wheezing may not be as bad as initially was, but they're still wheezing. They need another treatment because drugs are only going to have a peak effect. Now, some are short-acting, like epinephrine. Very short-acting, meaning as soon as we administer epinephrine, within 5 minutes, we're going to have this. But in the next couple of hours, phosphodiesterase is going to come in and break that effect down, and the patient will be here again. So we can't keep administering epinephrine. So then we'll have to make a choice of another beta-2 agonist to administer. Does this make sense? That's what that means. Everything that happens in your body, it must be broken down because it has to be metabolized and got out of your system. Anything you put in your system must come out one way or another. That's how your body is manufactured. Nothing stays in except stored fat. All right. Okay, so cyclic 3,5 AMP to cyclic 5 AMP. That simply means the breakdown of the drug. Breakdown of the drug. And so for you, what does it mean? You have to assess your patient, give them another treatment. If they're still wheezing, we're going to deprive them? No. Break the drug down, go back and give it to them again. Make sense? All right. Now, will we see this at cellular level? No. How do we know? We're going to go in and listen to the patient's breath sounds. We're going to ask the patient, how do they feel? Do you need another treatment? And if they're asthmatic, they'll tell you, yeah, I need one. I've been waiting. Ooh. They'll tell you, I've been waiting for you for the past 45 minutes. Yeah, you should have been here on time. And then you say, oh, I was changing the tank. They're going to tell you, I've been waiting on you. I've been short of breath. Because the enzyme phosphodiesterase has come in and broken it down. That's what that means. And then therefore, the next is says 3,5 GMP to cyclic 5, PNS. Same thing.
It's breaking the drug down.
Break any kind of drug down. We wouldn't administer this drug, but when you have an increase in 3,5 GMP, you have what? For an asthmatic? Bronchoconstriction. Okay? Asthmatic won't get out of this by themselves. But for us, when we have the PNS regulates our heart rate, regulates our respiratory rate, what it does, it continuously regulates it and it'll stop for a minute. But then the brain, the respiratory center, will send acetylcholine back to the lungs and say, okay, breathe again. So it's continuous. It's continuous. Continue, stop, continue, stop, continue, stop, continue, stop. AMP is SNS, GMP is PNS. Yes, sir.
There's no, so in bronchodilation drugs, there's no residual effect in as far as that could build up and actually kind of regulate itself. We're always going to continue treatments because once you stop.
What do you mean? What
Well, you know,
regulates
some
the-
drugs you take and it builds up and it actually lessens the effect in your body, so you get less and less of the dose.
Well, generally with respiratory drugs, we start out with minimum dose, and then we'll go to the maximum dose, and then it depends upon the state, the pathophysiology. Like COPD, you got stage 1, 2, 3, and 4. A patient in stage 4 will probably need more drugs than a patient in stage 1. So stage 1, they may just be fine with a 3,5 AMP bronchodilator, but stage 3 and 4, they need the synergistic drug AMP and decrease in GMP. You see what I'm saying? It depends upon the severity of the disease, and pulmonary functions will determine that. Yes.
Is it still the phosphodiesterase that breaks down the GMP?
No, it's another enzyme, but I'm going somewhere with here, but I'll do that Thursday. On that, on your sheet where I bypass methylxanthine drugs, I'm going to come back and visit this on Thursday.
And some people also process drugs a lot quicker than others, right? So
Yeah.
they're going to blow them out of their system in 2 hours versus a 4. And,
Right.
okay.
And that's why I'm saying if you do take drugs or if you do take vitamins or whatever, don't get upset when you see that it discolors or changes the color of your urine or even your bowels. Depending on what it is, you may not need it. My youngest sister, she's just 5 years younger than me, listening to somebody else and taking multivitamins with iron, and it turned her bowels black. I said, you don't need it. You eat like a horse. You don't need iron. Stop taking it. She listened to me. You don't need that crap. Stop taking it. And so she did. And she said, you were right. I said, I know it. You asked me. Yeah, some things we don't need. But my point is, it's good when you see your urine turn color or your urine smell good. I'm excreting it. It's a good thing. Kidneys are working, or you see your bowels good, it's coming out. Even when we have food poisoning and we become nauseated and we regurgitate, that's good because our system won't allow it to work through it. Because it's a possibility at a cellular level, whatever that poison is, it could actually get to your brain and begin to destroy neurons. So it's not a good feeling when you have diarrhea or you're throwing up, but it's good. It's protecting my system. And that's how we look at things. Most people don't know that, but it's a good thing if you're throwing up. It's good. Something's wrong, and it's a good thing. Your stomach is rejecting the poisons to protect the rest of your body. Okay? So hold your thoughts right there, and I'm going to come back to phosphodiesterase on Thursday and talk about methylxanthine drugs. Yes.
I had a question about the negative inotropic effect on heart muscle.
Yeah.
So it actually limits the contraction of the muscle itself?
Yes, it does. When it's run awry, yes.
So the expansion rate, that's how it slows the blood supply down. It just doesn't expand.
Yeah. Sometimes, I don't want to get too deep for you, but sometimes patients in septic shock, normal cardiac output is 4 to 8 liters per minute. Sometimes people in septic shock, cardiac output will increase to 10 to 11, and that's not good. It's too much. It'll overwork the heart. They give them a negative inotropic drug and control it. Sure will.
Is that because they're worried about the strain on the heart or the strain on the connecting vessels?
strain on the heart.
Or on the heart muscle itself?
When you overwork something, what happens?
You wear it out.
You wear it out. You only got one heart. Okay, before we go, any questions? Do I need to provide any clarity? Now, when I go over information, content, I'm holding you responsible. Now, I know you have an exam tomorrow, but you will have a quiz on Thursday on this sheet. You can go to the book if you like. I'm not disclaiming the book, but you should be able to follow this sheet and your notes. because what's on the sheet I'm going to ask. I'm not going to ask you about methylxanthine drugs, and I'm not going to ask you about I'm not going to do that. I'm not going to ask you about phosphodiesterase. But any term you see, you should be able to associate it with PNS or SNS. Got it? Any term you see, you should be able to associate with bronchodilation or bronchoconstriction. Any term you see, you should be able to relate it to 3,5-AMP or 3,5-GMP. If you can do that, you're doing good. Now, before I dismiss you again, are there any questions? Okay, I gave you PowerPoint 2. And on Thursday, I will give you more drugs. Erica, you sent me an email and you asked me a question. What's your question?
Yes. This packet.
And while Erica's formulating her question, if anybody else has one, I'll get to you.